You have a small finger-shaped pouch sitting quietly in your abdomen. Most days you don't even know it's there until it suddenly tries to kill you. This data visualization highlights the sheer scale of the risk. Look at how exactly 1 in 15 persons who face this emergency at some point in their lives. Yet, despite those odds, almost everyone ignores the early warning signs. The symptoms perfectly mimic an ordinary harmless stomach ache. The ordeal begins with stage 1. You feel a distinctly dull generalized ache centered right around your belly button. Because the discomfort is mild, it is incredibly easy to dismiss. The default reaction from almost everyone is to wait it out and do absolutely nothing. That mild discomfort is exactly what makes appendicitis so dangerous. By disguising itself as a minor inconvenience, it silently starts a deadly countdown without you even realizing it. Fast forward a few hours, the mild ache doesn't fade. Instead, the situation accelerates into something entirely different. This anatomical map shows the defining physical characteristic of stage 2. Notice how the pain migrates directly from the center of the stomach down to the lower right quadrant of the abdomen. Once the pain settles on the lower right side, its character changes completely. It stops being a dull ache and becomes sharp and intensely focused, getting progressively worse by the minute. The sharp pain brings along stage 3. The onset is immediate sudden nausea, vomiting, and total loss of appetite all at once. A low-grade fever sets in. Pain becomes so localized and severe that a simple physical movement or even a cough triggers an agonizing spasm. A general ache followed by this specific time sequence. The distinct downward migration followed rapidly by systemic illness proves your stomach ache has escalated into a time-critical emergency. To confirm what is happening, doctors rely on an immediate physical assessment you can actually perform at home, the rebound test. This is what the test looks like in practice. It requires applying steady firm pressure directly into the lower right abdomen and then suddenly pulling your hand entirely away. The result you're looking for happens on the release, not the press. If the pain violently spikes the moment the pressure is removed, the patient needs to go to the hospital immediately. Right in this agonizing window, patients often make a fatal mistake. The immediate impulse is to self-medicate to try and find some physical comfort. If the specific symptoms are present, there are strict rules for survival. Do not eat, do not drink, and under no circumstances should you consume painkillers. Taking painkillers artificially suppresses the very signals your body is sending. They mark the escalating severity of the pain, which heavily delays doctors from making an accurate diagnosis. Administering the rebound test properly and strictly avoiding medication are the two specific actions that dictate whether a patient reaches the surgeon in time. If that time runs out, the condition reaches its climax. The appendix physically bursts open, actively spilling localized infection directly into the entire abdominal cavity. At the exact moment of rupture, the intense internal pressure drops. The pain will briefly ease, tricking the patient into believing the worst is over and that they are actually recovering. This animation illustrates the catastrophic chain reaction that follows. The released infection spreads outward rapidly, causing sepsis, a systemic life-threatening bodily response marked by extreme fever spikes. Timing completely dictates the medical outcome. Caught early, the treatment is a routine, straightforward 30-minute operation. Caught after the rupture, it becomes a highly invasive battle for survival. The window between mild discomfort and severe internal infection is brutally short. Recognizing the strict chronological progression of those early aches is the only way to beat the ticking clock.